So, given the lead time for anything to change, should we be designing systems for anticipated need rather than current, e.g. coordination of referrals through an integrated system or that is accessible with patient permission?
It's like being on... Can you hear me on that? Good. Yes. It's like being on Q&A, isn't it? So we'll see how good I am. Anticipating need is a very good idea, and I think that clearly the first step in doing this kind of exercise is probably for people to sit down and say, well, what do we think the architecture looks like? What does the design of something like this look like? So some things that you have to decide probably are, all right, so how will we think about the organisation of these services into the future? So do we need something for the whole of the Perth metropolitan area? Do we need sub-regions for the Perth metropolitan area? What's the grouping? That's an important question to think about into the future. The second thing to think about is, so who is this for? What are these needs that you know, I've talked about 20%, but you can break that down so you can think about different types of needs. So at the moment, I understand that there's a discussion about urgent care needs and network for urgent care needs in Western Australia. So there's a question about what are the priority areas that you want to start with? Is it palliative care? Is it, you know, and so on. So so anticipating the needs, thinking about the design issues is probably a really important first step in terms of the future. And so work needs to be done. So conversations like this are the early step, and then the next step, if people say, yes, we think we want to do this, is to say, okay, well, let's get together between the department and PHNs and providers and consumers and think about, well, how would we do a planning exercise for this? What would the planning exercise actually look like? I've talked at high-level constructs. My job is to get you thinking about it, but there's a lot of work that would need to happen in taking the next steps.
There's a few questions around practical first steps. So you've started that, so I'll just build on from there.
Okay.
There's two questions here that are the same, so I'll just say it once. What would be the first step to enable a cooperative network, and are there examples of contracting methodologies that could be used in Australia?
So I'll take those as two separate bits.
Yep.
I think realistically the first step is this kind of exercise. So if everybody were to walk away from a meeting like this saying, well, that's just, you know, that you've just got it wrong. It's not that, it's something else. You know, the bigger issue is to try and deal with some other approach. The idea of network approaches is just the wrong way. Let's instead concentrate on expanding extended care organisations, or let's let hospitals move into the space, or let's throw the whole thing up in the air and get rid of PHNs and do something else. Then, you know, that would be a moment where you'd pause. But if everybody walked out saying, well, that sounds roughly right, and yeah, that's the sort of thing, that's the first step, getting agreement, that is something worth exploring. So let's assume that that's happened and that people think that that's a reasonable idea. Then probably the sort of thing that needs to happen is there has to be some agreement to have a go at some of this in particular areas and particular problems between the state government and the PHN and the Commonwealth. So some meeting of people like Leanne and the relevant people at the state and the Commonwealth level to say, yep, we've got an issue, and yes, this is worth exploring, and let's have a go at it. So let's say that that's happened and there is some interest in doing that. Then the next thing is for the PHN and the state to do some work to say, well, where would we like to try this? Where is the logical place to try this, and what does the scale of it look like, and so on, with a view to doing something which can be rolled out more generally. Because you don't want to try this everywhere all at once with every problem, because that's a recipe for disaster. So that's the sort of logical steps that I think need to happen. So that's the early sort of steps that, and we can go through design issues and so on. But you firstly have to get the key players to, there has to be general agreement that yes, this is worth pursuing. The key players have to agree, let's think about designing something at for a specific area and a set of problems, and let's try it, and let's put then the resources into doing the work.
Okay, I'm trying to stage these questions so there's some coherency, so bear with me if I get it wrong. I'll just say this one.
I missed the other question, which was the contracting.
Oh, the contracting, yes.
Okay. So there have been... we're not doing this in a vacuum. Other places have... Australia's a fair way behind in trying to come up with a model. So in the US, the contracting model is accountable care organisations. And essentially what happens there is there's a funds pooling arrangement. And the contract is really a set of providers getting together, and essentially what happens is they benchmark their performance against the general service system, and if they do better by working together to manage complex care, they keep the difference, right? So it's often in Australia it's called a measure and share arrangement. So you measure the performance and then you share the benefits as providers. So that's a model which has been developed in the US, accountable care organisations. In the UK, the model is essentially to develop networks like this, but there's a separate set of funding agreements, and the critical thing is the agreement between the providers to all do the sensible thing. That is, if you're going to have a whole lot of... My Amazon example, it wouldn't be very good if the post office says, well, thanks very much, yes, we'll participate with Amazon, but no, we won't do what you want. And the people providing my deck bag said, yes, we all agreed to participate with you and we'll sign a contract with Amazon, but we won't deliver it within 6 days or whatever the time frame is, and so on. So you need agreements where people actually sign up and understand their obligations and understand how it will work. It's not much use if you say, well, a critical thing in these models we didn't have time to do this, but a critical thing in these models is coordination of patient care. The consumer having a relationship with someone that they have trust in, who they can ring up in the middle of the night and that person will, or that agency will make things happen for them. Now, if the participating group in the network says, yes, we agree we have to have coordinated care, but then when the coordinator rings the GP and says, look, I really need you to do X, Y and Z because there's a problem, and the GP says, well, who the hell are you to tell me what to do? That's not going to work. Right? Because you're a nurse or whatever it is. If that's the kind of attitudinal variable that applies. So you have to work through those things so that people accept that. The other thing is, it actually turns out to be quite a challenge to be a coordinator. You have to be trained and you have to know. It's not the same as being a clinician, working with your colleagues and managing them. And you've got to do that in a non-arrogant way. You've got to do that in a way which solves problems and so on. So there's a whole set of issues that have to be worked through. And these agreements need to work through those issues to get that to work properly. You have to have agreements about business rules. Like, if it's an urgent problem, there has to be agreement about what urgent means. So there's a lot of work in what that contract looks like, what that agreement looks like. But other places have done that. And, another thing that you probably... I have suggested this, PHN CEOs love this, is do a study tour. Go and look at, the US and the UK and actually see where models that have really been well worked out operate, and look at how the business rules actually apply. The UK has nearly 30 years of commissioning experience now and has made a lot of mistakes along the way, but it's got a lot more experience than Australia has at this sort of stuff.
Just building on that, you mentioned the sort of navigation or care coordination. So the question is, who is the trusted navigator, and how does the trusted navigator bridge the gaps between acute and primary care?
So that's this is the critical element in all of the research on care coordination models for complex care. The notion of a navigator or care coordinator is really central to making this work, and the model really has to be one. This is where you operationalise patient-centred care or person-centred care, and the notion then is that these people have to have the skills and the competencies required to understand the clinical issues and the care issues and the service delivery issues which are there. So they generally tend to be nurses and allied health staff. Sometimes they're medically trained, but mostly they're allied health and nursing staff. So that's the first thing, is that's the group of people that you usually end up using for the care coordination role. The second thing is they have to be supported, because if they don't have authority and they don't have an actual a support organisation which helps them to actually manage all of this. Because the difference between my Amazon example and care coordination in the health system is that the Amazon example is routinised, and it just everything can be routinised. But in the health system, every individual person has to have it tailored for their own circumstances. So the care coordination needs to work that way. So they need an organisational framework in which to operate. So they actually have to be supported. And then the other thing that all of this stuff, the recent stuff like the Wagner model, which many of you may have seen, which comes out of Seattle, is that the other thing that you need is really, really good data systems and clinical pathway systems. So that you use that technology to actually glue it together. And the clinical pathways model is where everybody, the GPs, the nurses, the psychologists and everybody else sign up and say, yes, I agree to follow the clinical pathway. I agree that that's how we're going to practice for chronic obstructive pulmonary disease or diabetes or whatever. So that you don't end up with the care coordinator talking to a nutritionist or a dietitian, and the dietitian says, well, I don't do it that way. Right? That's not how I practice. I am exercising my clinical judgment here, and I do it my way. I don't do it your way. And that won't work, because I give you the example of why do we have hospitals and big institutional environments. The reason is because in those environments, when I was running big teams of staff, I had 1,000 staff. Well, the whole purpose of them working in the organisation was that we set up the rules within the organisation for how everybody was going to work together. And if people didn't want to work together that way, well, they could find somewhere else to work. But if you're doing a network arrangement, you have to get agreement about those things, because they don't work for you, so there has to be a form of working through. That takes a bit of effort to get that to happen. But that's the difference between whacking them all in the one big organisation, the extended care organisation, and having a network model. So if you think a network model will solve all the problems just because you've set up a network organisation, you have another thing coming. You actually have to do the work of getting people to agree to how the functional arrangements will work. Otherwise it won't work. So that's why I'm saying that you do need to start with developing these model agreements, doing the development work and so on to make it happen.
You have, in answering that question, highlighted that technology can be a real enabler across the spectrum of activity, whether it be the clinical pathway through to the permissions, through to whatever, because there was a question about that. This is a really important question. What is the role of the patient experience, or indeed patients generally, I say that, in designing or shaping the future system?
My analogy for this is a bit like, the one I use is so you've decided to build a house or renovate a house, and many of you have done this, and you decide that you want an architect to help you to do this. And so you say to the architect, I would like 2 bathrooms and a study and something for the kids and da-da-da-da-da. And the architect tells you what's technically possible and how this would be done, and does all the management of builders and everybody else. But the architect works collaboratively with you. You're not there trying to tell the architect, put that beam in there or put the electrics in there or whatever. But the architect isn't telling you how to live either, and not telling you what is important in your life. That's your job. So the patient is the person who knows how they want to live, what's important to them, how whether they want care here or there, how much things matter to them in particular ways. The job of the coordinators and the clinicians is to help them to get to those outcomes, but in technically feasible ways. and to help them to clarify what they want. An architect will sit down with you and say, do you really want to do that? If they're sensible. Right? So there's a collaborative exchange which goes on in these arrangements. Whereas too often in the past we've had two kinds of healthcare. One kind of healthcare is, I will tell you what you need, right? Doctor knows best, healthcare. That got replaced by recently, oh, we can't do that anymore, so we'll just put options in front of patients. You got option 1, 2, 3, 4, 5, which would, neither of those two models are any good. The model that's needed is the model that I've just described, which is where you explore with the patient what matters and what they want, and you help them to understand what is technically possible, what is not technically possible, what the limits are of, often the community doesn't understand the limits of healthcare. One of my interests in research is the limits of healthcare, and the limits of healthcare is healthcare today is like trying to fix a Swiss watch with a hammer and chisel. That's, healthcare can do some things, but it's enormously limited in what it can do. We all die. And the reality is we will all get into this frail period. And the difference between complex care and episodic care is basically about, here is an intervention that will probably have these effects and you'll probably end up, relatively better off as a result. Whereas complex care is often about managing things over a long period of time to help you to live in the best way possible, but not to help you that you're not going to overcome this. It will continue on. So that's what the partnership is about. It's like an architect with you trying to build your house. You don't want healthcare professionals telling you how to live.
Excuse me. We've got a few questions that sort of reflect some of what you've covered, but there's always this question about the investment required and the infrastructure to bring about, the Amazon experience, for want of a better term,
yep,
where primary care and integrated care can happen.
Okay. Look, my view is that essentially there is already a lot of money in the system and there is already an enormous range of services out there. There are some legitimate shortages and gaps here and there, but we could use the existing resources much better than what we currently do. That's a long technical discussion which I do, which is a different exercise, which is about what is the best funding system for doing this, and do you have fee-for-service, do you have capitation, do you have blended models and so on. How much money do you need to do these sorts of exercises? We're a long way off doing that. If we were having this discussion in the US, I would say, yes, let's have a talk about how those funding systems work and whether we use this kind of model for allocating the money or that kind of model for allocating the money. Australia is an enormous distance from that. The stuff which is being done in the healthcare homes trials is just bound to fail because it's too small a scale operation. The capitation arrangements are too limited in terms of what they're doing. It was always a poorly designed scheme. I think it's a step in the right direction, healthcare homes, and the idea of putting healthcare neighbourhoods around it is a kind of an approach to networks, and so that's useful, but it's an enormously flawed model. And essentially the Commonwealth has had no guts for a long time in terms of actually coming up with something. The coordinated care trials were much braver. They didn't work, but they were much braver than what the Commonwealth is doing at the moment. And that's because the Commonwealth is anxious about medical politics. And because the system works for 80% of the people pretty well. And it's that small, disadvantaged, frail group which it isn't working for, and they don't carry as much clout as... One of the things, and I'm happy to say this publicly, I think that the aged care lobby, for example, has been terrible at lobbying for older people. The disability lobby has been much better. The COTAs of the world and so on, which represent consumers, haven't done a good job. Been much too much playing insider politics with government. And should be standing up and saying, well, this is terrible. It takes a Royal Commission to actually demonstrate this at the moment. So these issues are real. And they're real in the mental health system too. And we've had many, many reviews in the mental health system as well. They're real in the alcohol and drug system, which almost never gets a Guernsey in this sort of space. People with alcohol and drug problems really get bounced around in the systems, and you look at the shortages and the lack of proper arrangements. People who the palliative care stuff, which of course is very hot in WA at the moment because of your upper house review. Has also, although to be fair, Perth has done better than because of the silver chain arrangement than other states. But in other states, it's awful. So there are those sorts of issues. So I don't actually think it's about a lack of money. There will be areas where more money is needed, but I actually think it's mainly about how you put the money together and how you make that run.
Just going backwards before we go forwards, there were coordinated care trials, which we've mentioned. There are also the super clinics in, was that 8 or 10 years ago?
Yeah, Nicola Roxon.
Yes. Where did they fit in this thinking?
Well, Nicola's very bright, and I'm very fond of her, but she got the wrong end of the stick. And she did a great job on tobacco reform, which many of you remember. She was the architect of the plain packaging. But the super clinics were really a capital investment strategy and putting people together in the one place. And that's a solution for 30 years ago rather than bringing them together digitally. And so the super clinics, I understand why she did it, and I understand what she was trying to do. She was trying to tackle the same problem we're talking about today. Really, she was. But it was the wrong solution to try and have a capital program to solve that problem. Capital matters. It's nice to have people together in the one room. I think there are important opportunities for face-to-face, but it's never going to solve the problems that we're trying to deal with. The problems are coordination and the things that we have been talking about.
So, in saying that, do you think the NDIS approach model being rolled out could be used as a blueprint for other aged care, for example?
I see people wincing in the room. Let me be clear about the NDIS. I think there are huge implementation issues. There's a set of issues about just having to roll out a system which goes from, which basically triples in size, and you think about having to employ all those staff, put the management teams in place, get the systems to work, sort out the reasonable levels of funding for different service approaches, the schedule of funding issues, the industrial issues which underpin all of that, the service development issues, getting all those new agencies in place, putting those local area coordinators in place. For those of you who don't know, the NDIS is essentially a system where you as a person with a disability, you show up, you get a plan from an independent area coordinator that's funded. The plan is funded, unlike the aged care system where there's a level of funding that you're allocated. Your funding is allocated to the plan, and then you have to find a service provider who can deliver that plan, and so it's consumer-directed care in that sense. Now, there are a lot of issues in that. It's too transactional at the moment. It's not relationship-based enough. There's enormous developmental issues to get this all in place. However, having said all that, so that's my caveat, the design is not bad. The design issues are reasonably well thought through. So the design issues are, one, it's all individualised to a person, right? Good. So you have a plan and it's individualised. The planning and the funding are separate from the provision. In the aged care system, what happens at the moment, so-called consumer-directed care, you get your package, it's allocated to a provider, and you then get the provider, well, you go and find a provider, and it's then allocated to the provider, and then you negotiate the budget with the provider and the services you're going to get with the provider. The provider's actually holding your money. And the aged care system, you get $50,000 packet, well, the average level 2 package is about $15,000. You get a $15,000 package in aged care, and that is then completely non-transparent in terms of what the money is being spent on. And I did a little study just the other day with some staff that I had them run the numbers, and we did a survey of all of the aged care providers providing home care packages, and there are 900 and something of them. And you can have the same package and it'll cost you twice as much with one provider as it does with another provider. The same package. So that system doesn't work well, and that's why the Royal Commission's having a go. The disability system works well. I think the design is okay because it separates out who holds the money from who provides the services, and you've got independent planners who are helping you to determine your plan. Now, it's not working well yet, but the architecture is better. The issue for this kind of system, if you had a network approach to dealing with chronic disease and complex care, then where would the coordinators be located? That would need to have some discussion. And what is their authority to get these people to work together? Should they be located within GP practices independently? Where should they be in that system? So there's some architecture issues that have to be worked through in making this work. But essentially, you need the coordinator to be both on the side of the consumer, so that they are sitting with the consumer, helping them to plan and do things, but have good relationships with the providers. You don't want an adversarial relationship in these spaces. So it's like they have to... Some people talk about this as being the third space, right, where the coordination sits with both outside the consumer world and outside the provider world. They have to have that mindset, which is... You remember my diagram about the services on the one side and the coordination on the other? That's the sort of approach you have to have in this. I'll just give you one little example. A long time ago, I did some work in workers' comp, and the thing was people weren't going back to work quickly enough. And we were all worried. And if you stay off work with an injury for more than 3 months, it's terrible. Things go badly for you. And you can often be off work then for years. And so this system in Victoria came in to try and deal with this. And one of the things was to get the medical staff and the allied health people and so on to work more consistently about a return to work plan. And I'm sure many of you will have had this kind of experience. And so we put in place these coordinators to do this, and we hired all these nurses and allied health staff, and they were hopeless at it. They didn't know how to coordinate. Because they didn't know how to ring up people and say, I've got person X and the plan is this, and I noticed you haven't done X, Y, or Z, or whatever. So we had to train them. So we set up a training program for them so that they could do that. So they had the clinical skills, but they didn't have the coordination skills to work with other providers to make that happen. And it's not the same as being in a hospital where if you've got authority, you can just say, I need you to do X, right? If you walk into the ward and say, I need X or Y or Z, then it happens. When you're dealing with independent, this goes back to that earlier point, everybody has to agree. And then you have to have coordinators who can make that happen. But they have to sit next to the patient on the one side, but have the confidence of the providers on the other. So it's a new way of thinking, really, in some ways. It's a new way of thinking.
So I've got a couple of questions here, again related, but one of them is a little bit of the magic wand, but I'm going to ask you the question, how do we break down the divide between state and Commonwealth so that we can truly embed coordinated care? And similarly, how do we move beyond the current sort of funding cycles that do align with terms of government?
Well, so there are two options that and the mental health report is an interesting example of it that's come out by the Productivity Commission. Look, in doing these things, the Commonwealth-state divide is usually thought of in a couple of different ways. One is the Commonwealth should run everything. Let's just give the Commonwealth responsibility for all of healthcare and get the states the hell out of it because they're hopeless at it. The other approach is the Commonwealth can't run a chook raffle, so let's get the Commonwealth the hell out of it and let the states run everything. And the reality in Australia is it ain't going to happen. I've been around for a long time, and the Commonwealth and the states are both going to continue to be involved in healthcare. So the question then is, what are the appropriate approaches to trying to sort this out? So my argument for a while with the Commonwealth has been you have incompetent regional structures. You're not good at running things from Canberra. So you need to develop what are called meso-level organisational structures to actually do the messy bit of this sort of thing, where you've got real people in the room and you're talking to them and you've got relationships with them and so on. And you have to create that and let go of the counting of every pencil and every dollar so that they can get on with doing this stuff. So I think what then has to happen is the Commonwealth has to create those structures and invest in them and then take a chance for 10 years instead of 10 minutes in getting those things to run. And there'll be some that go badly and some that go well, and that's the nature of these things, but persist in making it happen. And then there needs to be a negotiation between the Commonwealth and the states to use those structures to actually make things happen, which is why I keep coming and talking at PHN events, because I think that's the sort of thing that happens. Because the alternative is either the Commonwealth runs it all or the state runs it all. And I don't think that's happened. There is another alternative which has been tried but doesn't tend to work very well because of lack of trust between different political parties, is the notion of the Commonwealth, the state running things for the Commonwealth. So that the Commonwealth broadbands things and gives it to the states, and then the states run it. So the states becoming the agent for the Commonwealth. Well, that doesn't work very well. Because as soon as you get a government of a different persuasion, people, and you get ministers, you get terrific ministers, but occasionally you get people who are they just want to play politics with things, and then it just becomes a game, and then the next election is coming along and nobody trusts one another to do these things, and then the backbench starts to get irritated because something has happened in their electorate, and they start leaning on the relevant government to take it all back again. One of the things when I worked for ministers a long time ago was they like to announce things. And so the trick is not letting the announceables get in the way of real progress and to keep things sensible. So I think middle-level organisations which are a little bit of a distance from government are not a bad thing for making things work in the primary care sector. So I think that has to happen. In terms of the funding reforms to make that happen, I think the Commonwealth needs to I don't think we are at the point yet where we can go to the full-scale US or British kind of models. So we need to have an evolution to create blended arrangements so that we leave Medicare in place, because taking Medicare out is just a horrific idea because it'll lead to, just a riot to take that out. But adding to Medicare and adding elements to it which are not volume related. I used to talk about volume related payments and non-volume related payments. So we need more non-volume related payments. And you need about, I've always thought that you need about 10 or 20% of the money in the system being non-volume related to get people's attention. You don't need 100% of it. You just need enough non-volume related money to get people's attention. Because if 20% of your income depended on some agreement we had with you, you would be paying a lot of attention. When I was running big things, 10 or 20% got my attention. I didn't need 100% to be at risk. I just needed 10% or 20% to be at risk. And I paid attention at that point, a lot. So that's what I think is the sort of level of adjustment that's needed. Too much. At the moment, there's too much in the fee-for-service arrangements and not enough in the non-volume related arrangements. But we don't need 100%.
Okay, last question, and one that I'm not sure. Anyway, let's give this a go. I did mention it in my opening remarks. How do we build trust for collaboration in a context where more efficiency could mean fewer jobs? So the need to look after our staff, and how can that be the banner of collaboration?
The good thing about working in health is that short of an absolute economic catastrophe, which read the GST, then jobs in health will continue to grow. So it's unlikely we will see massive loss of jobs in health. Because the population is ageing and chronic disease is increasing and health expenditure has been going up as a proportion of GDP for the last 40 years. So it's very unlikely we're going to see that. The question of efficiency is a different question in health. The question of efficiency isn't so much cutting as it is in other areas. It's slowing the growth, right? It's not about cutting. It's about slowing the cost curve, flattening it. So in terms of doing that and maintaining trust, because people always see that, and the recent GP freeze was an example of where trust got problematic, is that you need to you need to take people with you on the journey of what you're doing. So when if you're sitting in an expenditure review committee of Cabinet in the Commonwealth, what happens is the Department of Finance shows up every year and says, the Commonwealth is spending $75 billion a year on healthcare. We need you to slow that to 6% next year or 4% next year or whatever it is. And then the bureaucrats go away and they try and figure out, what are we going to do? Are we going to freeze Medicare? Are we going to take the money off this, that, the other thing? What aren't we going to do? And then proposals show up, and that's the way that works every year. Then it gets translated through, and that sort of stuff is incremental management. It's not structural change. If you want to do this sort of thing, which we've been talking about today, structural change, you have to get people on board that this will work. And in order to do that, you have to have evidence, and you have to demonstrate it in practical reality, because there will be a million sceptics out there, and there'll be half of you will be sceptical about what I've said today, unless you can see it working in practice and you can actually see that it can be done. So the really important thing in these structural changes is to have models which can be demonstrated to work, and then to have them scaled. The problem in Australia is that we've had 1 million trials and we haven't scaled any of them. And so my discussion here today isn't to say, let's just roll this all out. This is a kick-off. For a series of discussions which will need to happen if this sort of thing rolls out.
Well, thank you very much. You're now off the hook in terms of questions. And apologies to any table, I didn't strictly read out your question, but we were trying to theme them and also get through a number. I have to say, thank you very much, Hal. My sense is for many of us, you've enabled us to spend, an hour or so thinking above rather than in the business, and just taking some time to go, yes, of course. And I think for those of us a little bit older, to see where we've come even just in the last 30 years, or let alone World War II. I mean, we forget how dramatic the changes actually are, both from health needs but also families and so forth. So I think you've left us with further conversations to have. There is no doubt there are a number of people saying, could we try that? Could we give that a go? What would that look like? Because I would imagine in this room, everybody's committed to getting the best possible outcomes for the people they serve and support. And we know there are conundrums and challenges, both as providers but also as consumers and receiving services. And how we bring that together is the challenge. So I'd like to thank you on behalf of the group. That's been a really interesting and valued discussion. So thank you very much.